All right, so now that we have taken and done a surgery in whatever setting, let's talk about the frontline chemotherapy. And again, this is our optimal, no pun intended, opportunity to impact survival, okay? So, Oliver, what's the community standard for frontline chemotherapy in newly diagnosed stage 3 and 4 cancer? It's a simple question. I know you're going to give me a complicated answer, but it's a simple question. What's the community standard?
The community standard is a simple answer. It's IV carboplatin Taxol every 3 weeks for 6 cycles.
Thank you very much. Paclitaxel and carboplatin. Okay. So in your practice, Leslie, what percentage of patients get IV carboplatin paclitaxel every 3 weeks? 100? No way. What percentage actually get that?
So the percentage that are not on clinical trial.
That's what I'm getting at.
Is about 20%, 20, 30%.
Is there any role for dose dense weekly where the paclitaxel is given weekly? You can give more of it. Obviously, there was a Japanese trial that suggested that was superior, but when bevacizumab was in the mix in American patients, it wasn't. Is there any role in today's world for dose dense weekly paclitaxel and every 3-week carboplatin?
Well, if you take the Japanese data and then you look at the subgroup analysis from GOG 262, where the 14% or so of patients that did not receive BEV, it was a post hoc analysis. Nonetheless, it did show that the dose dense did better. So if you're not using BEV, then you might need to be doing dose dense.
Have you heard of ICON 8? Are you familiar with ICON 8?
Yeah,
Tell me about ICON 8.
I believed that data until I saw ICON 8.
Yeah.
Tell them what that is.
So ICON 8 was a randomized phase 3 trial, frontline chemotherapy, standard 3-week dosing, standard dose dense dosing, and then no BEV, and then a weekly paclitaxel and weekly carboplatin, which came out of the MITO-7
in a third arm.
In a third arm. And there was just absolutely no difference in the progression-free survival between the 3 arms, and we know the toxicity differences with the weekly
So the argument for that is that ICON 8 has not been published. So until it's published, I get it. It's difficult to impact the NCCN guidelines. It will be published, and I'm here to tell you it'll be published soon, and maybe by the time you're watching this video, it's already been published. But I think the community standard remains every 3-week carboplatin paclitaxel. Now, there was a study that was published in 2018, in 2011 called 218, and it's 218 now, 2018. And that study added bevacizumab. And bevacizumab and carboplatin and paclitaxel, like you said, Tom, every 3 weeks, has been labeled around the world. And here at ASCO 2018, the final overall survival are presented. GOG 218, published in 2011 in the New England Journal by Robert Berger. What does the updated final overall survival show?
So the final overall survival shows no difference in outcome between the 3 groups. So randomized to the standard carboplatin and Taxol every 3 weeks with or without bevacizumab, and then a third arm that added a bevacizumab maintenance strategy and showed a progression-free survival advantage for the maintenance strategy, but no overall survival advantage among any of the arms. But interestingly and consistently between the sister trial, ICON 7 in Europe and 218, does show an hypothesis generating,
secondary
not confirmatory secondary analysis, overall survival advantage in the high-risk population, which most would consider, in the trials, was considered stage 3 suboptimal or stage 4 patients.
10-month overall survival in stage 4 patients if Bev is added.
Correct.
Is that a true, I mean, do you believe it? I get it, the clinical trial didn't test it, but Katie, do you believe that, let's say in stage 4 patients, that if you use Bev, the patients are going to live longer? Oliver?
Well, we see it again in 2018. We saw in a high-risk group in ICON 7, and that's actually exactly how I practice.
Tom?
Yeah, I think that data is real, and it is reassuring that that showed in 2 phase 3 trials, despite cutting the BEV in half and going with a shorter maintenance.
So, GOG 218 has been filed to the FDA. The action date is in late June 2018. It'll likely get approved. We've heard nothing to the contrary. is bevacizumab only for patients with high-risk disease? And remember, the study had there were no complete resection, essentially, no R0s in that study. So already the group is a high-risk population, but not the highest risk. Does this mean that maybe in our practice we should restrict the usage only to the stage 4s or large volume residual disease? What do you think?
I actually don't think so. I absolutely would want to use it in high risk, but the study was positive. ICON 7 was positive, GOG 218 was positive.
And it's positive for 6 months of PFS.
And that's a benefit. And so again, it's shared decision making with the patient. When you're setting them up for their therapy, they may not want to do that, but truthfully, I don't know any reason why I would not offer bevacizumab to an advanced stage patient who is undergoing adjuvant chemotherapy.
And Leslie, you have an interesting, we were talking off camera that you said, look, Brad, the neoadjuvant group, you said it, the neoadjuvant group is high risk.
Exactly.
So does that mean we should use Bev in the setting of neoadjuvant chemotherapy
I
too?
think they should absolutely be considered high risk. And interestingly, this trial was done in the 2009-ish era where we didn't really give neoadjuvant chemotherapy, and so neoadjuvant was not considered in this trial. But those patients, especially in the United States, those patients are your highest risk patients and would qualify under these.
So if you're going to use bevacizumab with neoadjuvant, you give a little before the surgery and after the surgery, just maintenance. How are you going to integrate? Because as Leslie said, the study was done in an era where neoadjuvant chemotherapy wasn't common. How do you integrate bevacizumab into frontline treatment when neoadjuvant is a lot of patients?
Well, technically, you're a bit restricted because of the surgery. Yeah. So you lose cycle 3, you're probably going to omit it because you're going to be doing surgery within 28 days. And then you may lose cycle 4 as well because you usually don't like to give it during wound healing for another 28 days. And so we'll stick to that answer.
I think that's fine. So Oliver, there's another overall survival final endpoint of another anti-VEGF agent, oral pazopanib. Tell us what that showed in the final overall survival.
Well, pazopanib is an interesting agent because it targets a lot of the VEGF receptor kinases, and has been studied for a long time and as a maintenance strategy after successful frontline treatment of advanced epithelial ovarian cancer. And we had the first data actually in 2014 that didn't show an increase in progression-free survival. We have now seen data that confirms this and doesn't show an increase in overall survival. Pazopanib is not a drug that's easily tolerated with a lot of side effects. So, you know, I think, Brad, that this has to be considered a negative trial.
Okay.
And I don't think that this,
and
at least as a single agent,
and
should
certainly
move forward.
didn't lead to regulatory approval. So, right.
Yes, I agree.